Good evening, everyone, and thank you for joining us for tonight's Adam Smith Institute webinar. I'm Morgan Schallmeyer, Head of External Affairs of the ASI, and I'll be bringing you another timely and hopefully fascinating discussion of rationing in healthcare. We'll be discussing why we need to ration care, how the pandemic has impacted access to treatment, and what we can do about it. So scarcity is regarded as one of the fundamental economic problems, arising from the fact that while resources are finite, society's demands for resources is infinite. We're increasingly able to do more with less, but whether it's time, money, people, or technologies, in the short term, we have a finite amount. Therefore, we must all figure out how to best allocate resources, namely through rationing. In healthcare, rationing is used to determine who gets what treatment and when. For years, the NHS has used the National Institute for Health and Care Excellence, NICE, to help ration services, whether that's determining the cost effectiveness of treatments or clinical care recommendations for patients. Beyond that, we also ration care through waiting times and consultations, spreading out demand of the system, hoping to be able to prioritize urgent care. We must always ration care, even during normal times, but the pandemic has drastically impacted the NHS's ability to provide regular care. Stories of delayed cancer treatment, sidelined operations, and instances of preventable diseases being missed have only increased as the NHS shifted to fight COVID-19 and patients shied away from GP surgeries and A&E. One BBC report even claimed that up to 10,000 Brits are at risk of going blind due to treatable and preventable causes because they are afraid or unable to access care. So coronavirus has laid bare the realities of rationing, but how a healthcare system chooses to ration their care always has real and lasting impacts for patients and doctors. Here to discuss with me why we ration care and what we can do to manage demand on a public system and how we adapt moving forward are three leading medical and policy professionals. Dr. Paul Bate is Vice President Commercial at Babylon Health. Prior to Babylon, he was on the board of the Care Quality Commission with responsibility for strategy, analytics, programs, and communications. Before that, Paul also served 2 UK prime ministers. He was David Cameron's senior health advisor and led on health targets and finances in Tony Blair's delivery unit. Dr. Lauren Skirles has over 25 years experience in the NHS as a private GP and working in the pharmaceutical industry. The last 10 years, he's been at the helm of Same Day Doctor, a series of private clinics. He has a deep knowledge of the demand from the UK population for private primary medical care and how best to serve this demand. Still practicing as a doctor within Same Day Doctor, Dr. Skirles is also a GP specialist in diabetes. And Dr. Christian Niemitz is the head of political economy at the Institute of Economic Affairs. He previously served as the head of health and welfare at the IEA, where he conducted in-depth research into comparative healthcare systems. His book, Universal Healthcare Without the NHS, delves into these issues. So I hope you'll join me in welcoming my guests, and I think we will turn first to Christian to give us his introductory comments on the ideas. We will then move on to a shared Q&A discussion and take questions from the audience. So please submit your questions using the Q&A function in Zoom. Christian?
Right, thank you very much, Morgan, and thank you all for joining. If we want to know which countries have been doing well during the pandemic and which have been struggling, the trouble we're facing is that there is no obvious measure of success here. It's not quite clear what we would be looking at. But if we had to go for a single indicator, then I suppose the best bet might simply be the excess mortality rate. The number of people dying over and above what you would expect in a normal year, given what we know about the demographic profile of the country. Now that's a fairly crude way of looking at it, because you're simply assuming that every death over and above normal must be because of the pandemic, but it has a couple of advantages, or it has two main advantages looking at it in this way. Firstly, you don't have to get into the whole discussions about whether COVID death rates are internationally comparable, the question of distinguishing dying with COVID and dying from COVID, all of that, you can ignore all that. And secondly, and that's particularly relevant to the topic of this evening, if you look at it in that way, if you look at excess death rates, you are also counting the indirect effects So the crowding out of conventional healthcare, the more intense rationing that has to be going on during a pandemic. So because you could in principle have a system that stops everything it's doing and deals only with COVID for the duration of the pandemic. If you did that, that would be the most extreme imaginable form of rationing. If you did that, you would probably have a low COVID death rate. But is that what we want? Probably not, because you would just have lots of people dying from other curable or preventable diseases. So what we want to know really isn't just how well a system manages to treat COVID patients specifically, but how good it is at managing overall resources, the prioritization, and making sure that apart from the pandemic, the normal things, you making sure that you just keep the show on the road. And if we look at the excess death rate, it looks pretty clear. What we see is that until about early mid-March, the excess death rate is close to zero, both in Britain and in most of the neighbor countries. Now that's unsurprising. That's what you would expect, because by early mid-March, nothing special had happened yet. From then on, we see a steep increase, both in Britain and elsewhere in Europe. But here we also see a divergence, because in Britain, the excess death rate is, first of all, the peak of it is higher than in most of the neighbor countries. And it also takes a lot longer for it to come down again. So there you can see not just the impact of the pandemic itself, but also of the rationing that's going on because of it and as a response to it. On that measure, Britain has been doing pretty poorly when it comes to dealing with the pandemic. We're not the worst. I know some newspapers have said we're the worst in Europe. That's not true either. Spain is clearly a lot worse. Italy is about in the same ballpark. But we're also very far from the best. We're clearly below average. It looks a lot better in the Netherlands, for example. They also had an early peak, but lower than here. And more importantly, they went back to normal quickly. Similarly, in Switzerland, they didn't even have that much of a peak excess death rate. And in the case of Germany, you can barely see anything at all. If you looked at the German figures, you would barely notice that this is an unusual year. So there are clearly cross-country differences in how well countries more generally and healthcare systems specifically have been dealing with this challenge. Now, to what extent is this attributable to the healthcare system and the way it's organized? Well, that's something that we don't really know yet, because there's lots of different factors that we would have to disentangle. It's not just about healthcare narrowly defined. It also depends on things like lockdown policies and social distancing measures, both the policies themselves and compliance with them, and loads of other factors. And as far as I know, nobody has yet managed to disentangle that. So we have to, what we have to do here is informed speculation. There is no hard science yet here. But let's just say I would be surprised if it turned out in the end that the NHS has been a star performer here. Because we know just from past experience that, that this always happens, that the NHS just doesn't deal well with difficult situations. So therefore, I was not surprised to see Britain having a higher excess death rate and a steeper curve than most of the neighbor countries. But we can see this every time when we have every year when we have the annual winter crisis, which is something that you don't get everywhere, and certainly not to that extent and severity. I remember during one of those winter crises, must have been last year, I was contacted by a journalist who said, we're looking for someone who can talk about how other healthcare systems are managing their winter crisis. Especially, they were interested in the German healthcare system. And I said, well, I can't really answer that question, because as far as I know, there has never been a winter crisis in the German system. And the journalist said, no, that can't be right. There must be one. And then I did a media search. I looked it up, and a media search in the German-speaking media. And to to see typing terms like winter crisis, healthcare hospitals, various synonyms of that, to see what they would come up with. And interestingly, the first few results that I found were about the NHS. So they were not talking about anything that was happening in Germany or Austria or Switzerland. They were talking about what was happening here in Britain, because the winter crisis was so bad that the foreign media was reporting on it. And then there were a couple of articles about football clubs, a football club that had lost a couple of matches, and therefore they were saying that they are in a winter crisis and one of their players had been hospitalized, which is why that got picked up, those search terms. And then the rest was about was about historical things, the hunger winter of 1947, the post-war winter crisis, and things like that. There was really no winter crisis as such in healthcare. And I did the same again for this event, for this seminar. Media search, are there any stories there of cancelled operations, postponed operations, more intense rationing, any of that? And the answer is yes, that does happen there. It's not just Britain, happens in probably every system, certainly the ones that I've been looking at now. And but the difference is, all of the stories that I've found, well, there was nothing dramatic about any of them, nothing that seemed particularly worrying to me, neither in content nor in tone. It was pretty much, well, it all read a bit like a Transport for London statement during an event, where they would say services are busier than usually today, so be prepared. You might not get the service that you get on a normal day, things like that. Okay, that's all perfectly expectable and not that surprising. And most of the stories about delayed access to healthcare and so forth, and illnesses that people had for that reason, was concentrating on the demand side. So people didn't want to go to a doctor, didn't want to go to a hospital, because they thought that's where you pick up the virus. So it's more a sort of demand side driven rationing because of maybe exaggerated caution, rather than the healthcare system as such not being able to deal with it. And otherwise, well, there were things like, well, there was one interview with a doctor in Switzerland who said, yeah, it's very hard to communicate this issue with patients, because in our system people are not used to waiting for healthcare. And this is the sort of story that when you read this, living in Britain, you think, well, it's a bit of a luxury problem. So it's the sort of problem that we would probably like to have here. So once again, the rationing problems, of course, as Morgan said, every system rations, with or without a pandemic. That's not new and not unique, nothing special about that, but it seems to be more bearable and more manageable in other systems, particularly in the more market-oriented systems on the continent. And I think it is, even though we don't have definitive data, definitive evidence either way yet, and I don't want to read too much into this. This is media stories. This is still somewhat anecdotal rather than hard science. I accept that, but it is still worth making that point now, because NHS worship is more intense than ever, and the cult around the NHS has, if anything, intensified during the pandemic. So it absolutely is worth making the point that the NHS is not a brilliant system, hasn't served us particularly well, and there are different and better ways of organizing healthcare. Thank you.
Thank you, Christian. I'd like to move on to Dr. Paul Bate now for his introductory remarks. As someone who's worked in and around the policy sphere, I'd really like to get some ideas of what you think about rationing in healthcare and where we go from here dealing with the pandemic maybe. So Dr. Bate, I'll leave it with you.
Thank you very much, Morgan, and thank you to everybody who's tuned in this evening, or where it is in the time zone that you're in. So I was listening with interest to what Christian was saying. My view of working across health systems around the world, first and foremost, is that there is no perfect health system. But one thing I think has come through loud and clear, actually around the world, but particularly in the UK, is the value that NHS and a lot of social care workers have provided in the time of coronavirus. And I think that's why some of what people refer to as the NHS religion is stronger than ever before. It's because of the ability of over 1 million people to go so far beyond the call of reasonable duty in pursuit of saving lives. And I think any conversation about health systems needs to start from that lived reality for what people do every day for the rest of society. Now, rationing is one of the biggest discussions in healthcare. Healthcare is one of the most exciting and important debates that we can have. To get my caveats out of the way, I'm a doctor, but I'm not a doctor of medicine. I have a PhD in particle physics, for what it's worth. The point of me saying that is that I've spent my whole career looking for exciting, interesting, and very big issues to get involved with and to play some part in solving. And rationing in healthcare is potentially one of the biggest. But my fundamental challenge would be is that rationing is necessary or a prerequisite, because it assumes that there's a level of capacity and there's a level of demand, and that the two are out of kilter, and therefore you have to do something about it. Let's find out if that's actually true. But I want to put something else on the table, and that's that if you change the whole model of healthcare, not just sickness care, but healthcare, then we can fundamentally change the equation between demand and capacity. So let me put it like this. There are two big challenges that the world faces, and it's not just something for the NHS. It's true in Africa, it's true in Asia, it's true in every continent and every population seeking healthcare. And the first is this, is that doctors, nurses, allied health professionals are expensive people to train and to pay. For a very good reason, they are experts in their field. Typically around 60 to 70% of costs in a health system go on the clinical workforce. So it's expensive. There's an economic question there. There's a second fundamental economic question, which is that the diseases tend to get more expensive to solve the more advanced the disease progresses. Now, clearly, right at the end, in the most tragic cases, that ceases to be the case. But in the main, and particularly for the large burden of non-communicable diseases, that is true. If you can manage someone's type 2 diabetes well and in the community, then the costs are much lower, the person stays healthier, their family has less fear in their lives. So it's actually a win-win. Those are the two fundamental challenges. And there is a way to solve them that doesn't involve crude rationing. And it's this, let's bring together three things that actually collectively bend that cost curve, to use the sort of economist term. Let's bring together the sum total of clinical medical knowledge and expertise. Secondly, let's use the remote devices and technologies in all their forms to break the need for there always to be the caregiver and the care receiver to be in the same place, because that is expensive and that is inefficient and is usually not necessary. And thirdly, more widely, let's harness the power of machines, the artificial intelligence, the machine learning, to do the most that we can do to take the burden off clinicians and enable them to practice at the tops of their respective licenses. We bring those three things together, then fundamentally we create a much greater capacity on the one hand to serve, and we get upstream of disease progression, which means that the total capacity needed in the expensive side and the painful side, which is the specialist acute sector, goes down. That's the hypothesis, that's the conjecture that I would put forward. But it isn't just a discussion, a debate, something devoid of evidence. One of the reasons I work for Babylon, and have done for several years now, is because that technology was something that Babylon was developing. That ethos, that approach was fundamentally at the heart of what Babylon was trying to do. Babylon was set up to put accessible and affordable health services into the hands of every person on earth. And that wasn't going to happen without a paradigm shift because of the economic challenges that I've touched on. So fast forward to where we are today. Babylon does more appointments in Rwanda than it does on any other country on earth. All right, and to compare health systems, clearly large parts of the developing world have an even more acute challenge than the more economically developed world, there are far fewer doctors and nurses per head of population. There is less money, there is less GDP per capita to spend on healthcare. We have found a model that allows us to look after over 20% of the adult population and growing in Rwanda. But we're actually live in about 18 different countries, so across Southeast Asia, in Canada, in the US. And let's home in on closer to home in the UK and in the NHS. So we started from this proposition: what would it be like if we brought the very best of technology, artificial intelligence and remote devices alongside clinical expertise and tried to change healthcare for the better? And we did that by setting up a primary care practice, an NHS practice, which is now, as it turns out, the largest NHS practice in the country, Babylon GP at Hand. And we said we were going to obviously adhere to every single safety standard and smash it. But we would also do two things which were not usual for general practice. First, it would always be open. We would put our marker down that accessibility means you don't shut. 24/7, 365 days of the year, access fast to clinicians, whether that's GPs, physiotherapists, pharmacists, advanced nurse care practitioners, whoever it might be, we'll get you that upstream care. And secondly, we'll do that. In fact, we can only do that because we'll deploy a digital first model. 90% or so of all appointments with a clinician are through our smartphones in the GP at Hand model. 10% still require in-face consultation because there are some things that are not going to be done anytime soon on a smartphone. And if in case anybody's wondering about that, it's not just the sickness care where you need to look in someone's ear to check if the infection is microbial or viral, but also health prevention, including cervical cancer screening, for example. All right, that is the model that we deployed, and we went live about 3 years ago. About 18 months ago, 12 months ago, the NHS England, having scrutinised right throughout the process what we were doing, quite rightly, carried out an independent evaluation. I just want to leave with one piece of data, and that pertains strongly to a challenge to why we need rationing at all. It turned out from the data independently collected by NHS England, not collected by GP at Hand, not collected by Babylon, that as a direct consequence, in a matched cohort study comparing propensity of healthcare need before and afterwards of a matched cohort, there was more than a 25 percentage point drop in A&E attendance for people who went on to register with Babylon GP at Hand compared to beforehand and compared to that matched sample who had also chosen to switch practices at the same time. That is important evidence that there is an alternative to rationing. So we may get to the stage where we have a much more efficient, much more accessible system where some level of rationing is still required because we continue to, we're mortal. There will always be things wrong with the human body and the human mind. But I would offer in this conversation that we don't need to start with rationing. We need to start with upstream accessibility, and that means great primary care. Thank you.
Thank you, Paul. That was perfect. That's absolutely the reason why I wanted you on for your expertise, to bring the discussion to how we reduce demand and we solve the problem of rationing instead of taking it as a fact. I'd like to turn now to Dr. Lauren Skirles, who is our last guest. As I mentioned, he is a practicing GP with same-day doctor and has 25 years experience in the medical health professional field. So Dr. Skirles, we'd love to hear your thoughts. Dr. Skirles, just kind of unmute yourself.
Yeah, my contribution is going to be much more prosaic than what we've heard so far. I've been a private GP for over 25 years, as you say, in central London. And I think that is an indication that people are prepared to pay for what I think we offer is good quality healthcare. So there is a demand for it, and no one has really tried to look at that demand and try to add it on to the health service. I don't believe that the NHS should be dismantled, nor do I believe that we should have a basic NHS and a top-up system that's supposedly superior. But I think we can integrate and take advantage of the fact that people are prepared to pay for certain types of access, maybe speed of access. Our average patient is not someone rich or famous. It's a young working person on perhaps slightly more than average salary who is too busy to get to see their GP or can't get to see their GP. There is a huge demand for that. And the fact that we've survived, I've survived as 30 years of private GP with no state funding whatsoever is testament to that. Morgan, you mentioned right at the beginning about waiting times, because one of the most efficient ways of rationing is the queuing system, and that's what the NHS uses to a great extent. And what happens with your waiting list is that people die on the waiting list, and therefore they no longer make demands on a health service. And the people who, the financiers who look at the health service do actually look at the things in this way. And it's in many ways a simple and rather brutal form of rationing, just to not provide the service so that people can't make their demand. I've often said, if, for example, people all could get to see a GP within a day or two, what would happen to demand? My feeling is demand would increase. The fact that some people can't get either a video consultation or face-to-face consultation for 3 weeks actually deters a lot of people. And that's, again, a very cruel form of rationing. And Parkinson's law could easily apply. If you improve the efficiency of the health service, the demand could even go up rather than go down. But I'm straying into the theoretical. I agree with what others have said, that COVID has exposed a number of faults in the NHS. I was fascinated that attendances at A&E went down dramatically. And I don't believe that this has caused, this in itself has caused serious health problems for the nation, because one of my observations is that A&E attendances are largely inappropriate. They're neither accidents nor emergencies, and that's something that needs to be looked at. Christian talked about comparing with other health systems, and what I see as one of the major problems of the NHS is it's over-centralised, and that Germany has a decentralised system where local decisions can be made. And as an example, we run clinics, 4 clinics in the UK. We made a decision not to close. We had a lot of pressure from doctors who were frightened about PPE, frightened about catching it, from our staff who were frightened about coming to work. And we could easily have decided just to shut up shop, but we didn't. We made a local decision. We put all the procedures in place, and not one of our staff, administrative or medical or nursing, has caught COVID from patients at all. I'm a great fan of having local decisions and decentralization. I want to take up Paul's point about remote consultations, because I'm a great fan of them. I've often said maybe the answer to the problem in general practice is to have more remote consultations. And what we've seen over the last few months is indeed the NHS GPs using remote consultations. But I have to say I'm disappointed. Rather, I thought I'd be pleased. I'm disappointed. I've seen some questions come up of people saying there have been huge complaints about patients not having access to face-to-face consultations. And I have to say that is the problem. I'll give you one example of many that I've seen. A man with urinary symptoms had 3 video consultations, and on each occasion he got 3 different antibiotics, and we all know how difficult it is to get antibiotics from a GP. He came in to see us. A simple dipstick test showed that he didn't have an infection, he actually had a kidney stone. Now, I'm not trying to say that we are fantastic, I'm just saying that's one of 100 examples I've come across where people are actually misusing remote consultations. It's all very well to provide that tool, but there needs to be better rules about using it as triage and not using it as a way of dissuading patients. And sadly, I think there are some GPs, not all, and not the majority, some GPs have used it as a way of hiding away from their patients and not fulfilling what they're supposed to do. And that's very sad indeed. we talked about the NHS being a cult, and I think that is a problem. I think the politicians know that. All the politicians I've spoken to know that you just can't tamper with the NHS. Even if they try to charge a £1 fee for access to the GP or NHS, it would cause ructions. And that's one of the big problems about making changes in this country. Which brings me on to another point that Christian talked about. He talked about the publicity and winter crisis. I had an Australian patient say to me once that every time she turns on TV, there's a story about health and the health service, and she simply couldn't understand it. This doesn't happen in Australia. And I know the Australians do have a very good health system, but I think part of the problem is the NHS is political. It's a political football, as we saw at the last election. And as we've seen during the COVID crisis, there are always these gotcha moments where the press try to catch out the health service. I'm not convinced that other countries don't have crises. I just don't think they care about it in the same way that our press tries to make us care about it. But I'm straying from my area of expertise into politics. I'll stick with one area of my expertise that Paul talked about, type 2 diabetes. And again, this is a rather crude and cruel analysis, so diabetes being my specialty. Of course, the more we improve the management of chronic conditions, the longer people will live, but then they'll live to develop more and severe complications such as cardiovascular or renal complications. And this is the other challenge of the health service. It's all very well saying we can improve things, but if people live longer, they're going to cost more. I'm reminded of the time a government minister said to me, oh, we don't mind people smoking. They'll smoke for 30 years and they'll die of lung cancer when they're 67, just 2 years after retirement. And they'll die quickly, so it's not an expensive way to treat. Now, that is how some accountancy-based people that run the health service think, or indeed have to think. And of course, the more we prolong life, the more we'll have an aging population, the more it's going to cost the health service. So in a sense, whatever we do, it's going to get more expensive.
Great. Thank you so much, Dr. Skirles. I'd like to bring back in all of my panelists for a bit of a shared Q&A. I think we have some bit of overlap and some bit of disagreement, so I think we'll have a bit of a good time. I'm going to bring Christian back in again because it's been a while since we've heard his dulcet tones. So Christian, my question to you is, many people will look at issues with rationing, issues with provision of service, and just say we need to fund the NHS more. But I think we know with our yearly issues with the winter crisis that you said that it's more than that. So what are some structural issues besides funding do you think that we can address in order to have an impact on the provision of services and how we go about getting people care that they need?
Right. Yeah, it would of course help to spend more money on the NHS. If you spend more on anything, you can provide more of it, and then you need less rationing. It's just that some health economist once said that you could, in principle, spend the entire GDP on healthcare. There is no logical upper limit. It simply depends on how much you lower the clinical threshold before somebody gets seen and gets the more complicated and costly treatments. That can all be done. We could, in principle, spend a lot more, but there would still be unmet demand. So the rationing issue isn't really a matter of the overall funding level. What would be alternatives to deal with it? Well, I mean, I would be very much in favor of having some pricing in there. It can be a modest share of co-payments. It can be, let's say you have a flat co-payment, a flat percentage, a proportional co-payment, let's say 10% of the bill of everything, but then cap that and make sure there's support available for people who can't pay it. I mean, that's how it works in lots of systems. Nothing exotic about that idea. But it can mean that you reduce unnecessary demand, and perhaps more importantly, if you do it as a percentage of the bill, that means that people themselves have an incentive to look around for whether there are more cost-effective options. In particular, so for example, some of the things We've talked about remote appointments, telephone consultations, maybe. These are things where, yes, the technology has been there for a while, and there have been attempts to shift more healthcare into that direction. It's just that there's not, from the patient side, there's not much of an incentive to use that. At the moment, we rely on the goodwill of the patient, that they will choose those options, and the same has been true in, I mean, Paul talked about the issue of getting more people treated in primary care before they access the more expensive, complicated, higher tiers of the healthcare system. Yes, sure, that is the way you will have to do it. It's just that I remember reading about the Blair reforms from the early 2000s, late 90s, and that was an issue already then, that they thought, oh, we'll just set up a few independent treatment sectors, independent treatment centers, as they call them then, and that will massively relieve the hospitals, because then everyone will go to these centers. And yeah, it happened to a small extent, but nothing like what they expected. It's been an issue that's been around for years, and that's where I think having a bit of a financial incentive could help. If you know that if you use these low-cost, less complex forms of healthcare first, then you can save quite a bit of money. I think that would be the way to go.
Right. Another follow-up question I had, you mentioned it a little bit, Christian, I mentioned it in my intro, is we've always been learning to do more with less. So one of the ways that you overcome and you grow, especially through innovation, is you learn how to achieve more with fewer resources. So that brings me to Paul. You already said you work for Babylon Health, which is an app-based healthcare provider. And I wanted to hear a little bit about how you think we can encourage more solutions like Babylon. Maybe not so much that you get some direct competition, but making sure that more people can access solutions like this, and even paying for it if they have the ability to. So how do you think we as society, either through policy or innovation, encourage more solutions like Babylon?
Thank you. So competition is a good thing. It's a great thing to say at the outset.
I would agree,
isn't it? But it's fundamentally a good thing where it acts in the interests of the consumer or the patient in this case. So I think the question was what can be done to make it a more plural supply side, more people wanting to provide more innovative solutions. Well, I think that's relatively simple. And actually, a lot of the policy framework in this country is already in place. And it all comes down to making sure that people are not disadvantaged by bringing in innovation, that there is a fair playing field, as people talk about, and that's why that's actually already written in law. But that's by far the best thing I think you can do is create the environment in which those who provide great care are able to flourish. The way in which care is paid for in the UK, in the NHS, clearly capitated in the main for primary care, but a much more complex mix of fee-for-service, effectively payment by results, which obviously really payment for activity, with some cap budgets in secondary care. I do think that the capitated system is a much better system to work in, as long as there are quality markers around that, so we don't repeat some of the problems in the US of the 80s. So line in the sand, enable people to flourish by having a fair playing field for people to bring in. That, however, is not easy, because it tends out to be not the letter of the law that's a problem, but really the vested interests, who are often quite powerful in many fields, as people know, and sectors, but some of the most powerful groups exist in healthcare. And they exist in healthcare for a very good reason, which is an incredibly emotional transaction to put your life in somebody else's hands and rely on their expertise. There is an inherent power imbalance in that. So there are going to be the conditions for vested interests. So the thing I always think is most important, beyond having a fair playing field in the legislation, is that that's actually enacted on the ground, and that people who are making policy and translating policy are very live to the realities that vested interests often have power, and power can often be misused. So it's very important to be watching that the reality actually plays out in the way that policy making intended it to be. And linked to that, the point that Lawrence made about the NHS is political and ends political football. That is absolutely a statement of fact. But I cannot imagine an NHS without politics, for the simple reason that the NHS is a tax-funded, free at the point of need service, taking around 8% of GDP and obviously a larger percentage of the tax take. Politics is about the allocation of resources in society, as well as other things. And consequently, it is simply political. So we can't really look at this just through an economic lens. We have to look through the lens of what people actually want and are willing to vote for. Thank you.
I mean, I want to piggyback off the idea of making it a conducive atmosphere to increase access to alternative options, and ask Lawrence about his experience setting up a private practice. Yeah. You said in an interview with the Evening Standard that one of the hardest things about your job is all of the regulation, all of the paperwork. Yeah. Yeah. And I wanted to ask, what do you think we can do to make it so that private practices are more common, so that it maybe drives down prices, so that the average man can access a GP appointment for preventative care, for example, going back to the issue that Paul said about down the line treatment and getting preventative care, yearly physicals, that sort of thing.
Yeah, I mean, I think regulation, not just in private practice, regulation in general has become a problem. And since Harold Shipman and the introduction of revalidation, that's made things much, much worse. And I think this extends right across the health service. What's happening, for example, in the hospitals now is that the rules are saying we can't do this, we can't do that. People have got to have COVID swabs before every procedure. And there's no nuance in this. And that's part of the problem. Once you introduce regulation, they're regulation, and people can't make a judgment whether to follow or not. They have to follow them. I can't see this going backwards. When in the days when you could have meetings, I would go to a meeting of GMC responsible officers. I'm an RO. And we would be 300 doctors sitting in a room, none of us seeing patients that day. In fact, most major hospitals will have a responsible officer who never sees patients, that his or her job is just to be the RO. The regulation is overwhelming, and I can't see a way out of that. For private practice, you know, we were the first people to be inspected by the CQC and its predecessors. Simple things people don't understand. You can't just open up in an office. You have to have a D1 medical license, which is difficult to get in some areas. You have to have the CQC will come and inspect you. In the old days, you had to have certain type, well, even now, you have to have certain type of wash basins and so on. When the CQC come to us, they will have 3 people spend a whole day going through everything from a list of every cleaning product we have and all its components. We have to produce that and update it. And that's just one example of thousands of pieces of paper that we have to collect. It actually gets easier with time because you just shrug your shoulders and say, we'll just do it. But it's expensive. We have to have staff whose job it is just to be the CQC officer. And I don't think, I'm not convinced CQC regulation or revalidation has necessarily improved healthcare in primary care at all.
I'd like to see if Paul has anything he'd like to say in response to that as a former board member of the CQC.
Yep, I'm brought in CQC ratings for general practice. So I think Lawrence makes some really good points. So every hour away from a patient is a patient not being seen. Your small businesses. I don't think regulation is a good thing or a bad thing. Well, actually, I think regulation is a good thing. I just don't think it's black and white. Regulation has to be done well, just like commissioning has to be done well and provision has to be done well. But I do know this, and it's why I say I think it's a good thing. I don't want to get on a plane which isn't regulated. I don't want to go on a plane where the pilot isn't professionally regulated, as well as Boeing or whoever it might be being regulated. I certainly don't want to go anywhere near a nuclear power station that isn't regulated, and I don't want my healthcare to be in an unregulated industry, whether it's the medical devices, professional regulation, or the organizational regulation. So I think the question is really to make sure it's done well. I think in general practice, without wanting to sort of stick too much off the topic tonight and rationing, quite frankly, prior to regulation coming in, I have no understanding of how people knew what a high quality general practice was versus low quality general practice, because I saw no performance measures that described outcomes. I see very poor reporting of safety incidents on the NRLS, which still continues today. So yes, I think there are problems with the regulatory environment, and there always will be. We have to improve them. But I would challenge in a safety critical industry like healthcare, what happens if you don't have regulation?
All right. Well, I think that was as I was writing those questions, I wrote in a right of reply for you, Paul. So thank you. I want to talk about rationing. One of the main ways that we ration healthcare is through price. So we do that in the United States, and not to say that that's the preferred system, because the debate is very often a binary. If it's not the NHS, then we're going to be stuck with the US system, which no one here is advocating for. So my question is, maybe Christian, this could be one for you. How do we, in fact, you mentioned bringing in price as an option. So how do we possibly bring that into a discussion without reverting to a binary? If it's not the NHS, it's the US, which I think is a false dichotomy. And I think we can all agree that's a false dichotomy.
Absolutely.
Yeah. Well, first of all, I don't want to ration access exclusively by price. I mean,
Right.
I am a free marketeer, but on some issues, and healthcare is one of them, I am not a purist. I guess some of your more purist libertarian listeners would say I'm unsound. I'm a bit of a wet on healthcare. I think there is a role for the state in ensuring that everybody has access to a well-defined minimum package of healthcare. You can then, of course, have market pricing and determining access through prices. If you want to go beyond that, that's all fine. For the basic package, no, I think your income shouldn't matter, and therefore that should not be determined through price. However, even there, you can have areas where, I mean, in some of the systems, in some of the alternative systems that I describe in my book, you can choose between different health insurance policies which offer different levels of provider choice, for example. You can choose an option where, in Switzerland in particular, you can choose an option where you have unlimited access to any medical provider in the country. You can go directly to a specialist, you can go directly to a hospital, no limitations whatsoever. But that's also the most expensive option. You can agree to opt for an insurance policy where there are some limitations of provider choice. For example, that could mean a gatekeeping system like here in Britain, where you need a referral from the GP first. It could mean that the insurer has a predetermined list of providers. Let's say there is a local hospital that they have a preferential contract with, and you will have to go there first. And these are all ways in which you can save money on healthcare. If you don't value that choice very much, you can go for those cheaper options. In that sense, yes, that level of provider choice is rationed by price. However, that doesn't mean that a rich person necessarily gets better healthcare than a poor person. It just means that if they choose those options, which will be, of course, easier if you're rich, then you have a lot more convenience. But that doesn't mean that your clinical outcomes will be worse. And I think it's absolutely fine to ration access to convenience in that way, that their money can play a role, that you get cheaper and more expensive insurance options. Now that's of course something which requires a pluralistic system. I can't see how you would replicate that in the NHS. That's where you would have to have system level change. You would have to move to an altogether different system. I'm just saying you can have a high degree of consumer choice and even cheaper options where you can save some money without that meaning poor people die earlier.
Right. I mean, I think that's one of the very difficult parts of the discussion when you're bringing in any alternative system, the idea that you can still have access, universal access, and free at the point of use for people that need it, while offering an alternative to people to access something different to lessen the strain on the public system. We have about 10 minutes left, so I'd like to ask one final question to Paul and then maybe go to Lawrence and Christian for some short wrap-up thoughts. So Paul, in your role at Babylon, I imagine you kind of think 5-10 years in the future for what you'd like to see for Babylon, but what do you think are the larger trends in healthcare in the next 5-10 years, especially focusing on rationing?
Well, I mean,
the big question.
Thank you. The big questions. I mean, we have to break this down in some meaningful way. So there are some very big blocks of technology which I think will absolutely transform healthcare as we know it. One of those is the advent or the next generation of machine learning and artificial intelligence, whether it's the work that we do or published on causal inference, or whether it's on image processing. There's a huge array. But that's just one of the technology frontiers I think is going to get broken through. Personalized medicine is one that people talk about. Immunotherapies. There are a whole series of separate medical technologies which I think are really going to change. Interestingly, I think that may just cause people to stop, and I really hope it does, stop thinking about technology as a woolly enabler. It is one of the most frequent things you see in the kind of the policy world is the little blue bar at the bottom of a slide which says, and we'll use technology as an enabler. There is nothing enabling about a radiotherapy machine or a LINAC. There's nothing enabling about a stethoscope. It gets to the heart of the problem, or the lungs of a problem in the case of a stethoscope, and fundamentally changes the caregiving process. And we're going to see a lot more of that. So that's one thing. The second thing is that we're going to see huge, that inevitably there will be economic changes in the world. We don't know what they are, but we will see shocks. As we see shocks and we see growth, we will see changes in healthcare because people will have to make choices. And with an aging population and the increased proportion of spend which is going on health and wider social care across the world, that is coming to a tipping point where there are some very big political choices about whether we will be able to continue to fund growths in healthcare at the same time as provide other critically important public services. So I think that's it. And then of course the third piece will be whatever comes of this wave of this particular pandemic and how that changes our approach to healthcare and our views. We've touched on this a couple of times about what it's meant for people's views of the NHS and I suspect systems around the world. So those are macro social consequences. And it wouldn't be fair, I think, to finish any conversation about healthcare without also talking about the impact globally of climate change and access to clean water, access to resources. And if we don't think those consequences through a healthcare lens, then we are missing the trick and just looking in a very insular way at old school sickness care. The reality is that all of those things are changing, but it also makes it one of the most exciting and important things to be working on in the world today.
Thank you. That was a great summary. And I like your distinction that you've made a few times between sickness care and healthcare. The idea that we can work on issues before they arise to solve some issues down the line. We have, again, about 5 minutes left, so I'd welcome some closing statements from Lawrence and Christian if you have any, and if not, that's fine.
Yeah, very quickly. Morgan, you made the point about binary choice between NHS versus USA and how false that dichotomy is. If you want to look at another system, look at France or Germany. France have a very reasonable co-payment system at general practice. The last time I used a doctor in France, something like 15 euros I paid, the state paid another 15 euros. That's much cheaper than someone coming to see me, for example, in central London. I think that system works in Germany. It's largely insurance-based, and again, I think that works very well. And you're absolutely right. We must move the discussion onto those sorts of areas.
Christian, would you like to add to that? Or?
Yes. Well, I think the topic we've been talking about today, rationing, is going to get more intense. We have an aging society for demographic reasons alone is going to increase. And yeah, as is usually the case, I think the NHS will not be well prepared to meet the challenges arising from that. I think that there is a political will to spend more on it, and that is going to happen. But there will, apart from the political willingness, there will be an upper limit at some point. We are probably quite close to a maximum taxing capacity, whereas there are no obvious areas where you can where spending cuts would not be politically controversial. So something will have to give one way or another, and that will make the issue of alternatives, particularly alternatives that are more market-based, offer greater choice, and make that kind of purely political rationing less relevant. That will become more pertinent. I don't think it's going to happen. I'm not expecting to see fundamental changes on the policy side of healthcare in my lifetime. I think the NHS will remain a sacred cow. I don't see that changing over the course of my lifetime. I think that those of us who make the case for a more pluralistic system, a more market-based system, we're fighting for a lost cause here. We will not see victory, but nonetheless, we have to keep doing it anyway, simply because if you are, broadly speaking, economically liberal, whatever that means in detail, your opponents will always use the NHS as a stick to beat you with. They will always say, you're a bad person, you want the US system, you want the poor to die. And that means that even if you know that it is a lost cause, you cannot simply opt out of that debate. And that's why we have to keep fighting the lost cause.
That's exactly one of the reasons why I wanted to have this discussion. I thought the reporting about missed access to care during coronavirus kind of, again, laid bare this underlying issue that we deal with all of the time, and our inability to have kind of productive discussions about how we structure the NHS and the policies that go into it really just allowed this to continue. And like Paul said, it doesn't have to. We don't have to keep doing this crude rationing system if we can welcome ourselves to alternatives. So with that, I'd like to thank all of my panelists for joining me and everyone that joined us. The questions that were submitted, I pulled some of them in advance and incorporated them into my questions. So thank you so much. If you enjoyed this, you can watch it again on YouTube or on our website. And you can join us next week when our Head of Government Affairs, John McDonald, talks about housing with another expert panel. We also have a weekly podcast called The Pin Factory, which you can access on all of your major podcast providers. So thank you all so much for joining, and we'll see you next week.
Thank you very much.
Bye.
Thank
you.